Good afternoon, everyone, and welcome to the MCO Managed Care Organization webinar. This is the first of two webinars that we'll be presenting, and I'll be talking about that in a little bit. My name is Tina Nye, and I'm a senior fellow at NORC at the University of Chicago, and I'm joined today by my NORC colleagues who will be presenting, and also our partners at Spire Healthcare Strategies for the webinar today. NORC and our partner Spire are operating the Medicaid Managed Care Organization Learning Hub, which is funded by the Robert Wood Johnson Foundation, and are hosting a two-part webinar series to disseminate information to the field on Medicaid and Medicaid Managed Care basics. Our partners on this project are several, and they include America's Health Insurance Plans, AHIP, the Association for Community Affiliated Plans, ACAP, Community Catalyst, and Families USA. Through our early discussions with various organizations as part of this project, we learned that among many stakeholders, there's a great interest in learning more about Medicaid fundamentals as they are involved with Medicaid and Medicaid Managed Care organizations. And the purpose of this webinar is to address some of those questions. What I'd like to talk about now is a little bit about the webinar logistics for today. All attendees will be on a listen-only mode. And please use the chat box at the bottom, you can see that, to ask any questions. We'll have two question and answer breakouts. One will be at the first half of the presentation, and the other will be at the second half of the presentation. So please send us any questions that come up while the presenters are presenting. The slides of this webinar can be accessed at our website, and the link is provided right here. What I'd like to do right now is introduce our first presenter. His name is Scott Weitz, and he's a colleague of mine at NORC. He's a senior fellow, and he's the project director for the Medicaid MCO Learning Hub. Scott has a lot of experience, as you can see from this slide, and for over 20 years he served in a range of high-level state positions in Minnesota, including serving as the Minnesota Medicaid Director, as CEO of the State Health Insurance Exchange, and as the Minnesota State Health Economist. With that, let me turn this over to Scott, and he'll talk to you about Medicaid basics. Scott?
Thanks, Tina, and good afternoon, everyone. I'm going to provide an overview of Medicaid and Medicaid Managed Care, and I'm going to do this at an overview level with an eye towards setting up some of the subsequent presentations in this webinar series. A little bit about Medicaid itself. Medicaid has been around for over 50 years now, having been established in 1965, and it's a shared federal and state program where states operate their individual Medicaid programs with flexibility underneath some broad federal guidelines and rules. In doing so, states share in the financing of the program, with the federal government financing anywhere between 50% and around 80% of the Medicaid program, varying that on state per capita income, with higher income states receiving somewhat lower federal matching, federal medical assistance percentages. States are required to cover certain mandatory populations under Medicaid, including low-income children and pregnant adults, seniors and people with disabilities who receive cash assistance through SSI, and certain other very low-income parents and caregivers. But states may also receive Medicaid funding for optional populations, and one that you might be quite aware of is the Affordable Care Act gave states the option to expand Medicaid to adult populations with incomes below 138% of the federal poverty guidelines, and 37 states to date have expanded Medicaid under this option. And then finally, state Medicaid programs have to cover certain mandatory services such as hospitalization, physician care and other things listed on the slide here. But they also have the ability, in addition to those mandatory services, to cover optional services such as prescription drugs, dental, vision care, and things like personal care attendance. In terms of the scope of the Medicaid program, Medicaid covers around 75 million Americans. It covers 1 in 3 kids, and as a result of covering so many children, it covers about half the births in the United States. And as I mentioned earlier, elderly individuals and persons with disability are among the mandatory populations covered under the Medicaid program. And so about 1 in 7 elderly who are enrolled in Medicare are also enrolled in Medicaid. We call them the dual eligibles. And 10 million people with disabilities are enrolled in Medicaid. Almost a quarter of behavioral health spending is financed through the Medicaid program, and the program itself costs around $600 billion. And you can see in looking at the swath and the array of people who are covered under Medicaid, it really covers many of our most vulnerable, low-income children, people who are elderly and low income, and then folks with disabilities. And it's really set up that way by design. The program has grown over time. This chart shows the growth of the program over the course of its existence since the 1960s. And you can see that both enrollment and spending have grown over the period of the program's existence. To give you a sense, though, of how it's grown relative to other healthcare, in 1990, or if you look at all the spending that was done in the United States, about 10% of healthcare spending was financed under the Medicaid program. By 2018, 16% of overall healthcare spending was financed by the Medicaid program. And that's a result of both growth in enrollment in the program as well as growth in the costs of the program that have driven it to become somewhat more disproportionate in spending than it was earlier. As I mentioned earlier, Medicaid is a comprehensive plan that's designed to meet the unique needs of those it serves. So the needs of a kid on Medicaid in terms of healthcare services are likely to look very different than the needs of an elderly person who's enrolled in the Medicaid program. And this chart sort of captures that differential that exists. For example, for children, the gray area of the slide, of the bar chart, which is the second bar chart in, shows that around a little over half of the payments that are made by Medicaid go to managed care organizations to sort of manage the care for that kid, or to the right of it, that adult. And that very little of that spending goes for things like long-term supports and services. But if you move to the right for the disabled and the aged, you see in the green at the top of those bar charts, or the sort of light blue hashed part of the slide, that somewhere between at least a third for the disabled and over 60% for the aged of Medicaid expenditures really go for long-term supports and services, which is very different than it is for different populations. So again, the program itself serves a wide range of types of enrollees, and the needs of those enrollees vary a great deal. And that's also going to be captured on this next slide. You can see on this slide, which shows enrollment versus expenditures, on the left-hand side, of all the people enrolled in Medicaid, 40% of those enrollees are children. But children, on a relative basis, are relatively inexpensive to the program and cost the program only about 19% of its overall expenditures. By contrast, if you move to the top, in the light blue and the gray portions of the bar chart, the aged and persons with disabilities account for around 23% of Medicaid enrollment, but their expenditures are more than half of the program's expenditures. And of course, that's a function of the fact that the elderly and the disabled have higher healthcare needs, and the types of needs that they have are more expensive because of the types of individuals that they are. As a result of the healthcare cost growth that I've just shown in some previous slides, as well as the concentration of some of that spending among certain populations within the Medicaid program, states face these same cost pressures. As I mentioned earlier, the Medicaid program is financed by both the federal government and state governments need to come up with a matching share to fund the program. As a result, they are under cost pressures. Medicaid is a large expenditure in any given state's budget, and so states have increasingly turned to Medicaid managed care to help better manage their programs and hopefully bring more effectiveness and quality outcomes to the program. So why do states use Medicaid managed care? Well, most states do have some form of managed care in place, around 40 states. Medicaid MCOs provide a comprehensive set of acute care services, and in some cases, and I'll touch on this in a few minutes, long-term services and supports to Medicaid beneficiaries. And in exchange for providing that care, MCOs are paid a set per member per month payment for these services, and then they are at financial risk for delivering those services as specified in the contracts that Darren and Tom will touch on a little bit later in our second presentation today. States have moved to Medicaid MCOs for a range of reasons, including seeking to increase budget predictability. When you're paying a set per month per member payment, you know what your outlay is going to be each month and have some predictability as a result of that. They've done so to increase or improve access to care and access to providers. When Medicaid first came up back in the 70s and 80s and into the 90s, there were frequently challenges in finding providers willing to serve the Medicaid program because of the lower payment rates that Medicaid has, and also creating a clear point of accountability. When states look to their Medicaid program, having a managed care organization as under contract to deliver services to enrollees means that they know where to be able to push and to be able to have accountability for the delivering of those services. So how widespread is Medicaid managed care? Well, this chart shows that around 40 states use capitated managed care models. That's the dark blue and the sort of lighter blue portions of the chart. So about 80% of all states who have turned to Medicaid managed care as a form of delivery for at least some of their populations. In terms of the percentage of enrollees who are enrolled in managed care, around almost 70% or around 69% of all Medicaid beneficiaries are in managed care. Some states have a larger share of their Medicaid population enrolled in managed care. That's the dark blue states on the chart, where in those states at least 75% of folks enrolled in Medicaid are enrolled through a managed care plan. And as when you move to the lighter colors, that's a somewhat less rate of penetration. One thing to note is that states have the option to move whichever populations they feel they would be best be served by managed care into managed care. And so the states with less penetration of enrollees in managed care frequently have not enrolled, for example, disabled populations or elderly populations into managed care. And that's sort of represented in this next slide. The way to sort of interpret this slide, I'll start with the second bar in, which is children. Of the 40 states who are operating capitated managed care programs, in 36 of those states, at least 75% of the kids who are enrolled in Medicaid are enrolled through a managed care plan. Similarly, on the next slide over of the states that have done Affordable Care Act expansion, most of those states have moved at least 75% of those enrollees into Medicaid managed care. But if you move further to the right, for states that are using Medicaid managed care for the elderly or the disabled, in those states you see that the penetration rates are lower, that a smaller percentage or proportion of enrollees who are enrolled through managed care or are enrolled in those managed care plans, with 21 states having 75% or more of the elderly and disabled enrolled. And you can see moving down that the bars look a little bit different than they do for the other populations. I'll hang with that last piece just a moment. As we noted earlier, a lot of the expenditures, or a higher proportion of the expenditures in the Medicaid program for the elderly and disabled, go for long-term supports and services. Those are needs that those populations in the Medicaid program have, and they are frequently just a higher proportion of the expenditures for that population enrollment group in Medicaid. And many states have now started to turn to managed care to help better deliver those services and hopefully bring greater effectiveness to those programs. And about half the states now operate their long-term supports and services under Medicaid managed care organization contracts. You can see that this has sort of evolved over time with some early adopter states, the light blue states, having managed long-term supports and services contracts in place in the early 2000s, and that's sort of expanding over to the darker blue states and then the green states until we're at a point now where about half of the state have those types of programs. So I want to pause here and say we're going to move in this next section of the conversation to really talk about, we've been talking a little bit about managed care, we've been talking about populations who are enrolled. I want to talk now about who are the carriers, the actual managed care organizations themselves, who cover individuals under managed care. It's an important thing to understand. Every state contracts a little bit differently for managed care and has a different mix that changes over time in terms of who the carriers are who are providing managed care services to Medicaid enrollees. So this next chart really shows if you took all the Medicaid enrollees who are in managed care and looked at the health plans that they are in, that's what this chart does. I'm going to break this into three sort of chunks. The first is on the left-hand side of the slide, where you have 6 large multi-state parent firms, Centene, United Health Group, Anthem, Molina, WellCare, and Aetna, who combined have about 44% of the folks nationally who are enrolled in Medicaid managed care. On the right-hand slide are what we would call sort of local or regional managed care organizations, and there's 144 of those as of this slide's making, accounting for a very similar share of the overall market, about 44%, give or take. And then the remaining 12% are 13 multi-state firms, similar to the ones on the left-hand side, but simply with a smaller market share. In terms of geographic spread, I'm going to concentrate on the left-hand side firms, those 6 large parent firms that we talked about. Of those 6, you see that they all operate in 10 or more states. So when you think about working with your local managed care companies, sometimes they're going to be local companies, which were represented by the right-hand side of that pie chart I just showed you, and sometimes they're going to be these larger national firms. For example, United operates in half the states in the country, and you see Centene and Anthem operating in nearly 20 states themselves. And so just important to understand what the makeup is and what the reach is of some of these large managed care organizations. And the final thing I'm going to touch on before we turn to time for some questions is really talk a little bit about some of the options and strategies that states follow in thinking about the different approaches that they can take in looking at managed care contracting. Again, the way that states will deliver services for enrollees in the managed care program is they contract through procurements with managed care organizations, and then within that, it's important to also remember that states, under a broad federal framework, have a lot of flexibility in terms of how they actually design their individual state Medicaid programs, and contracting with managed care organizations is one of those flexibility areas. And states do use different approaches for managed care contracting. Those can include the 4 sort of broad areas I have listed on the left-hand side of the slide. The first being the financial arrangement that they have with their managed care organization. Are they operating a full risk contract, or a partial risk contract, which might include something such as risk corridors. Oftentimes, when states are bringing up a new population into Medicaid, they'll create risk corridors, which means that they want to create a situation where, in addition, where a managed care company which is at risk for delivering services because of the capitation rate, they will build in a little bit of a buffer, so that if managed care companies lose too much money, there's some risk sharing and buffering that occurs on that side. If they're making too much money, they'll buffer on that side. They also vary in the amount of authority that's granted to the managed care organization. States can be very prescriptive in terms of what they allow their managed care companies to do, or they might want to allow some room and flexibility within their contracts for managed care companies to innovate. States have options in terms of who they bring into managed care, and they have a number of options that are listed there, kids all the way down through the dually eligible. And states take different approaches to that. And then they can also vary on the services that they include in managed care contracts. Typically, they would include acute care services, but oftentimes you'll see where pharmacy or behavioral health or dental can be either carved in or carved out of those and managed separately in some cases. And as we mentioned earlier, long-term supports and services has become an increasing focus area for managed care contracting. And states use different approaches also in terms of how they think about the procurement itself. Which geographic areas do they want to cover in a given in managed care contracts? Are they doing it regionally? Are they doing contracts statewide? The number of plan partners that they choose is something states have options on. CMS does require that enrollees have at least a choice of 2 plans. But states vary on the number of plans that they bring in to the Medicaid program. States vary in terms of the contract terms, how they structure those. Sometimes they'll be, as we bulleted out here, a 3-year contract with 2 option years, or they can be for a longer time horizon. Typically, managed care organizations want somewhat of a commitment of knowing that they're going to be managing a given population over time, and so they might want that 3-year contract, but then the options to renew. And then finally, the contracting process can vary. Some states use an open process where they set rates, and any plan that's willing to take those rates is able to operate in the Medicaid managed care program. Alternatively, some states use competitive procurements where the choice of who gets to operate in the Medicaid managed care program is dependent on both the price and quality bids coming in, with states selecting the most price competitive and quality competitive of the Medicaid programs. And my last slide here to conclude is just a little bit that there's a lot more to come, I think, on this particular topic. States are continuing to explore transitions to managed care. 2 prime examples of that are North Carolina and Oklahoma, who are where the state Medicaid programs are considering very strongly moving. There are strong discussions that are occurring in states such as Arkansas and Alabama. We've mentioned earlier that managed care has a strong role in integrating care for the dually eligible, and states have a lot of interest in that area, and that is an area that is likely to continue to grow. And then finally, as the social determinants of health continue to play a very important role for state Medicaid programs, managed care will likely equally play a key role in the integration and coordination of those services. By last count, about half the states in the country who had managed care were using their contracting mechanisms to, in some way, shape, or form, encourage or require managed care organizations to address the social determinants of health through their managed care contracts. And with that, I will pause and would be happy to answer any questions.
Scott, that was really terrific information, and we really appreciate the information that you provided. We have some questions from the audience, and hopefully none of these stump you. But the first question is, what age is considered aged versus newly eligible adults, which I assume is the expansion population? So could you talk a little bit about the distinction between who the aged are and the newly eligible adults?
Sure. It's a great question, and we use different terms sometimes interchangeably. When I was talking about the aged in this context, I'm really talking about folks who are Medicare eligible individuals. So those would be individuals over the age of 65 or older who are eligible for the Medicare program, who also, because of their income level, qualify for the Medicaid program. And then Medicaid assists in payment for services that aren't otherwise covered under the Medicare program. The adult expansion population is really for folks who are adults but under the age of 65 and who previously in most states were not eligible for the Medicaid program. And they now are eligible in those expansion states up through the income of 138% of the federal poverty line. So that's really the distinction. It's a 65 and plus or under 65 adult population distinction.
Thank you, Scott. That was a good answer. Correct. Next, we have a question about Medicaid managed care company rates. And the question is, what about rates? Many pay less than fee for service. And then going along with that question is, can states set a floor below which Medicaid managed care organizations cannot set rates?
It's a great question, and I don't want to steal Tom and Darren's thunder since the second portion of this presentation today is going to really focus on that rate-setting process. What I will say, though, just to not completely avoid the question on my portion, is that states are required through their rate-setting process to set what are called actuarially sound rates. And that means that the rates that are set have to be able to support the delivery of services and be able to support both the delivery of services, payments to providers, and be set at a stage such that the managed care organizations that are delivering the services don't, in a sense, go out of business. They have to be paid enough so that they can sustain the amount of payment that's going out to providers and payment for those services. So states have the ability, they work with their actuaries to set those rates. I know that Tom and Darren are going to dig into this in a great deal of depth, and I would certainly encourage folks to ask questions of them during that portion of the presentation, but I at least wanted to tee it up at a high level since they'll dig into it a little bit deeper.
Scott, the questions are coming in hot and heavy, and what I want to tell everybody is that if we don't get to your question today, we'll reach out to you and respond to your question separately if that makes sense to you. One of the questions that we have, and I think this might be the last question we have time for, are there any current pilots or projects to point to as evidence of success with Medicaid managed services, quality, and social determinants of health? And Scott, you might want to make a plug for this particular project, which is looking at some of those issues.
Sure, it's a great question, and there's a lot of innovation in this space, and I think a lot of interest in how managed care organizations can work more closely with community-based organizations and others in improving things around the social determinants of health. One example I'll talk a little bit about is some work that's being done in Arizona through a program called Circle the City, which really focuses on engaging around homelessness and around services for those individuals, where there's been a lot of success in finding alternative ways to ensure that folks are housed and find alternative ways that the managed care organizations can support that work. So that's one example just off the top of my head. I would encourage folks, we'll send out the link to that program, by the way, but I would also encourage folks to, this project is very much focused on how managed care organizations working more closely with community-based organizations can really improve on the health equity and health outcomes of Medicaid enrollees. And so I would encourage you all to visit the Medicaid Managed Care Organization website for information on those exact questions.
And also these slides are available at that website as well. Again, given the time, we need to move on, and I'm very sorry we have some great questions out there pending. It's hard for me to move on without answering them, but we will get back to you to do that. So thank you so much, and thanks for the people that are listening in for asking such great questions. And Scott, that was terrific. So now we're going to transition to Medicare or Medicaid managed care organization financing. And our next speakers for this are Tom Betlach, who, as you can see from this slide, has tons of experience with Medicaid and Medicaid managed care. He was the Medicaid director in Arizona and the deputy director before that. He was the budget director, so oh boy, does he know about financing. And he also was the former president of the National Association of Medicaid Directors and the vice president. And he currently serves on a CBO panel of health advisors. We have two presenters during this section, and the other presenter is Darren Gordon. He too was a Medicaid director, and he too was a Medicaid deputy director, both in Tennessee. He too was a former National Association of Medicaid Directors president and vice president, and a MACPAC commissioner. So we're excited to have Darren and Tom present. Darren and Tom will provide some background and concepts on Medicaid financing of Medicaid managed care organizations, and talk a little bit about MCO rate setting, the use of population risk groups, different approaches that states can use, and information on reserves and how they're used and best practices, which I know it's a lot of information that you're very interested in learning about. So with that, I'd like to turn to Darren, who will talk, and then he'll turn it over to Tom. Thanks, Darren.
Thank you, Tina, and thank you, Scott, for really setting the groundwork here for us. I know Medicaid managed care financing may not be exciting to everyone, but it's obviously a very important thing for the Medicaid program given managed care's role broadly across the country. So as you heard about managed care's prevalence growing in Scott's presentation, this slide is to represent how managed care has grown from an expenditure perspective. And as you can see here, in federal fiscal year 2007, Medicaid managed care represented 19.5% of overall Medicaid expenditures. And that has grown quite significantly to the latest year data is available, which is federal fiscal year 2018, at a rate of 52.1%. Now, there are a variety of factors that have contributed to that growth. So over time, you've seen states expand what all managed care might cover. For example, they may move new populations into managed care, or they may add new services into managed care. But another factor at play here, obviously, is overall inflation and medical costs, whether it be new therapies, new treatments, or just the overall cost per unit inflation that we see in healthcare. All these contribute to some of this growth as well. And last but not least, changes in enrollment will also have a role here. As you know, that this span of time also captures when the ACA Medicaid expansion took place. So that's a factor here as well, worth noting. So with managed care playing such a significant role in Medicaid, we thought it was worth spending some time better understanding how it's financed. Again, may not be the most exciting topic, but one that we feel is very important in understanding Medicaid managed care more broadly. So what we've done here is we've included a variety of key terms that we think it's helpful to be familiar with. So capitation payments, which is terminology we frequently hear in Medicaid, are the fixed per member per month payments that a state pays to a managed care organization on a prospective basis to provide the services for which that managed care organization is contracted. While not all states use this concept, the concept of reinsurance is one that is fairly common in the insurance world more broadly. This is a method by which the state shares in the financial risk over a predetermined monetary threshold with the health plan. Then there are risk-based contracts, and these are contracts where the MCO assumes financial risk to provide the services set forth within the contract, and whereby the MCO may incur losses under that particular agreement. Now, risk-based does not always mean 100% of the risk is borne by the managed care organization, but that there is financial risk at some level. Rate codes and eligibility codes, these are classifications where members are placed for capitation payment purposes. And risk groups are a collection of rate codes that are paid at that same capitation payment rate. So how individuals are classified for purposes of payment. Risk corridor, it's a phrase that has been heard more often as of late. In essence, a risk corridor is a financial arrangement that limits the overall losses and gains experienced by a managed care organization. As a tool, risk corridors are often used when there's not sufficient historical experience with a particular population or a particular service type, or there may just be great uncertainty due to other factors. For example, the pandemic that we're currently experiencing. Medical loss ratio, often referred to by its acronym MLR, measures the portion of the capitation payment that is paid for healthcare claims and or certain quality improvement activities. The managed care regulation at the federal level has established an MLR target of 85%, and some states require plans to have at least an 85% MLR or rebate the difference back to the state. Now, it's very important to understand how program design influences rate setting. For example, as the state integrated physical health and behavioral health. Some plans have all of these services listed here on this page integrated into managed care, but other states have certain services carved out. So those carved out services may be carved out into another managed care organization. For example, you may have a separate behavioral health organization, or the services may be carved out and handled on a fee-for-service basis. That will vary state by state. Either way, the rates paid to the plans are only for the services for which they have responsibility. For example, those services and populations that are carved in. So we listed some examples here of the types of services you might see carved out. Another not on this list that we're seeing carved out more often than not is pharmacy. A variety of factors drive why a state may choose to include or exclude a particular service from managed care. Those decisions not only drive how a state sets the rates for their health plans, but how members interact with the system, how providers engage with it, as well as the incentives and disincentives embedded in the system, intended or unintended. The process of setting capitation rates for the health plan is one that is of great importance, particularly in those states where the managed care proportion of the business represents a large percentage of the overall program expenditure. As part of that process, the actuaries review actual, complete data for the market in which the rates are being developed. That typically includes actual experience over a multi-year period. This information or experience is gathered from the encounter data and other financial information as appropriate to give a clear and complete picture of what's actually happening in the market on the ground. This analysis helps to inform both underlying trends in utilization and costs by service provider type and by eligibility rate cells. Also, as part of this process, the state must work to ensure that the actuaries are taking into account potential changes in policies or policies that have occurred, changes that may have occurred between that historical data that the actuaries were looking at and the beginning period for which rates are being developed. Now, whether these plan changes are plan changes in benefits or provider payments or other coverage decisions, they may impact the cost of the program in the future and has to be considered as part of the rate development process. The result of this exercise produces a rate range. There are a variety of assumptions that are at play in anticipating how the past experience may inform the future and how future changes may impact experience as well. At the end of the process, the state, working with the actuaries, must select a specific rate within that range by rate cell. As we reflect on the slide earlier in the presentation that expressed how much of Medicaid expenditures go through managed care, it is easy to understand how significant this process is. Either overfunding or underfunding the program comes with consequences. So it's very important to get this right. Now I'll turn it over to Tom to take the rest of this presentation.
Thanks so much, Darren. It's great to be with everybody today. So I'm going to build on Darren's comments just in terms of the rate setting process. And states go through this at least on an annual basis, and some states update their rates more frequently over the course of the year. But it starts with that process that Darren described in terms of pulling the data, pulling the program adjustments, looking at trends, and developing the rate. Then working with the state. Oftentimes states rely on consultants and actuarial firms to do the rate setting process, and so there's a back and forth with the actuaries and state leadership to ensure that all the programmatic changes are accounted for and to really review some of those assumptions that are part of that overarching rate development. Those rates then typically go out to the MCOs for review, and I think it's important to get an extra set of eyes on those rates, to have your plan partners understand what the assumptions are that are built into that. And sometimes we would use that period to be able to get feedback on additional information. And I think of something like the hepatitis C drugs that came to market, and just seeing what the utilization was of those and being able to make sure that was getting built into the rates appropriately. The rates then go to CMS, and CMS has taken a much more active review process of the capitation rates. So CMS does their process with the Office of the Actuary, where they'll engage in a dialogue back and forth. The documentation process associated with capitation rates has become much more extensive in terms of the information provided. And you can actually find some of the actuarial certifications out online for states that are approving the capitation rates for their managed care partners, typically after CMS has approved them. And then finally, that CMS approval process does take place. Sometimes that actually occurs after the start date of the contract, and states need to make a decision in terms of whether or not they're adjusting their rates at the start of the contract or waiting for CMS approval. But again, this process plays out on at least an annual basis and sometimes multiple times within a year. Darren talked earlier about risk groups and the ability as part of the managed care process to bring together certain eligibility groups into a risk group and to look at the costs and the outcomes associated with those populations. And so the example provided here looked at Arizona data, and from an overall population perspective, it's around $6,000 per member per year. But you can see the vast differences that can occur within various populations. So for example, individuals with serious mental illness obviously have considerably more resources being put into capitation to address their behavioral health needs, and individuals with long-term care also have considerable more resources built into the capitation rates for long-term services and supports. Children with special health care needs address those special health care needs in terms of the higher costs associated with that population. And for a population like foster care, again, you see the overall costs, but the way that capitation rates are built, you can see quite a bit of underlying and granular detail in terms of what types of services that population is seeing. So that we know, for example, in the foster care population in the state of Arizona, $15,000 per member per year, and 85% of that is behavioral health. So recognizing the importance of behavioral health for that population and ensuring that there's adequate resources getting built in to those capitation rates, and then tracking the outcomes associated with that. So the ability to look at risk groups, the ability to identify certain services for those risk groups, and then make sure that funding is getting built in, and then the ability to track and trend what's going on within those risk groups over time is really the ability of managed care and what that type of structure allows for at the state level. Darren talked about some of the expectations and the framework for the capitation rate setting process. And there's also flexibilities that are built into that for states and thinking about how they want to leverage managed care and what type of expectations. And a question was asked earlier, can states set floors in terms of what the expectations are for managed care organizations to pay providers? And the answer to that is yes, states can set floors. In addition to that, states can use directed payments, which are established in regulation, that give the state the ability to have value-based programs in which the state identifies the structure of those and has the managed care plans pay providers based upon that value-based payment structure. So it gives you the ability to do an incentive payment program for nursing facilities or hospitals and to be able to make those payments through the managed care organizations as part of the overall capitation rate development and then as part of the rates that are paid from MCOs to providers. Darren also talked about the importance of risk corridors and the fact that with the pandemic, we've now seen over 80% of states surveyed and responding to that survey with the National Association of Medicaid Directors saying that they're imposing risk corridors to deal with this period of uncertainty in which when the pandemic hit, we saw a significant decrease in utilization. And so states appropriately so have been putting in place risk corridors to limit overall profitability or to potentially limit overall losses that might occur within managed care organizations depending upon what's going on with their expenses within that rate setting year. Risk corridors can be symmetrical, asymmetrical, or tiered. So for example, a symmetrical risk corridor might be plus or minus 3%, and anything above or below that, the state is taking on the cost. Asymmetrical might be plus 4% or minus 2%. And a tiered might be plus or minus 2%. The plan is responsible for the first 100%. 2 to 4%, it's shared 50-50. And then anything above 4% either comes back to the state as a profit or the state covers that loss for the managed care organization. And then finally, risk adjustment is another flexibility states have in thinking about rates. There might be plans in which individuals, because of a plan's network, that are higher cost may select that plan on average at a higher rate than other plans. And so risk adjustment tools allow the states to make a budget neutral adjustment to the capitation rates and reallocate the dollars based upon the risk of the population and how that population might have chosen to select certain managed care organizations. In terms of state best practices on capitation and oversight, we've already highlighted the importance of encounter data and how that drives rate development and the expectation that states have the data really that's necessary to set those capitation rates, identify cost and utilization trends, and that encounter data is so important in ensuring its overall completeness. The next is ensuring that states are evaluating managed care financial performance on a regular basis. And by regular basis, I don't mean just annually. There should be a more frequent review of the financial performance of managed care organizations and a comparison in terms of how plans are performing to the capitation rates that are being set so that Medicaid leaders have insight in terms of what's happening within the marketplace. There needs to be consistency in terms of policy development. Sometimes we see not necessarily the connection between a decision a state might make and then capitation rates. And so states need to work hand in hand with policy development, whether that be through the legislature or internally, and ensure that the capitation rate adjustments are being made to reflect that. Another good practice is a third-party audit in terms of reviewing plan performance to ensure that there's a third party really reviewing what's going on within the plan's finances and to conduct those audits on a regular basis. Tracking and trending overall capitation rates, that was something we took on as part of our overall strategy, and really it became one of the key metrics for our dashboard, and I'll talk more about that in just a minute. Capitation rates really give you the ability to be creative in terms of how you think about programmatic delivery. And a great example of that is in the long-term care space. And more states have gone to this strategy of using a weighted average between nursing facility and home and community-based services. And the question was asked earlier, why do states look towards managed care as a delivery system? And the reason is managed care has flexibilities that states do not. And as for example, a state like Arizona has been able to move to over 75% of the population that is at risk of being in an institution like a nursing facility, being able to be served in the home and in the community. And that is because the plans have been able to develop a robust network of home and community-based services. But the state has helped incentivize that through the capitation rate structure, which looks at the weighted average of nursing facility and home and community-based placements. And a nursing facility placement is about 3 times that of a home and community-based. And then the state's taken a weighted average of that and assumed that there will be continued progress in terms of overall use of HCBS and less use of nursing facilities. Another best practice in terms of capitation rate and financial oversight is to leverage encounters to ensure appropriate third-party liability and coordination of benefits. So Scott already talked about dual eligibles and the fact that there's 10 million individuals who are on both Medicare and Medicaid, and Medicaid's responsibility to coordinate the benefit there. There are also individuals who are enrolled in the Medicaid program who might be enrolled in commercial coverage. And so with Medicaid being the payer of last resort, it's incumbent upon the state and the managed care plans to work together to ensure that the benefit is being coordinated and that commercial coverage is primary coverage. And so an example of a best practice might be that a state would not receive an encounter from a plan when it knows somebody has third-party coverage unless they see that the benefit has been coordinated. Finally, there's the opportunity to leverage capitation rate development as part of a managed care contracting process. And you can do that both on the programmatic side and or the administrative side. And it gives the states really the ability to highlight that. Of course, states' best practice would be to set a floor. I talked earlier about capitation rate trends and the way to measure that and really look at what's going on with overall programmatic expenditures. And you can see an example of that from Arizona in terms of looking at the period before the Great Recession, what transpired during the Great Recession in terms of capitation trends on a per member per month basis over the course of these years, and then what's transpired going forward. And then finally, I just wanted to spend 1 minute on reserves. And reserves, I think, oftentimes get confused, and it's important to understand the role of reserves. So reserves are something that are set either through a Department of Insurance or a Medicaid program within a state. There's something that's set aside to ensure there are liquid resources available, that should there be challenges financially with a plan, should a plan look at exiting a market, to ensure there's resources available so that liabilities don't fall back on the state. And so it's really dollars that have been put aside to ensure, and those dollars need to be relatively liquid, and there shouldn't be a lot of risk in terms of any types of investments associated with those dollars. And I think we are seeing states starting to identify opportunities in terms of using some of those reserves, and not necessarily just wanting them sitting there, but potentially looking at investments around social determinants of health. So as Darren said, it may not always be the most exciting topic, but I think that you can see there's clearly a lot of interesting moving pieces as it relates to managed care and financing. And with that, Tina, I'm going to turn it back to you. I know we've got just a couple minutes for questions.
Yeah, thank you so much. That was such good and useful information for everyone on the webinar today. We had a question, and I think you teed this up really well, Tom, with your last comment. And that question is, can you talk about social determinants of health strategies and how they're paid for and how this may evolve? I know this is a favorite topic of yours, so you can expound on it.
Sure. So I'll start, and then Darren can jump in and offer any insight he has as well. So social determinants, I think, are coming from different buckets right now. The first is, in some instances, plans are using some of their limited administrative resources to put forward. In some instances, states have community reinvestment requirements so that if there are profits at the end of the year, a certain portion of those profits have to be reinvested into community projects, which certainly can address social determinants of health. We've seen in some areas, and I mentioned this just previously, but some plans identifying the opportunity to use some of those reserve dollars for investments in the social determinants of health. And we've also seen with CMS's approval of the North Carolina waiver, the use of 1115 waiver dollars to address social determinants of health. On the Medicaid programmatic dollar side, it's more challenging because states can only build into capitation rates those services that are covered within that, and there hasn't been an expansive use of services that can be really tied. There's employment support and housing support services that can fall under the Medicaid benefit, but it's still somewhat limited on the benefit side. Darren, did you want to add anything else to that?
Yeah, the only other thing that I think it's worth thinking about is how value-based purchasing and social determinants of health is really interlinked. When we thought about value-based purchasing back in Tennessee, part of the rationale was to be able to reimburse providers for non-traditional billable services that can improve the overall health of the individual. So I really do see where through various value-based purchasing models, they can provide added incentive to providers that do look to partner with CBOs and others in addressing some of the social determinant of health needs.
Are there any other questions, Tina?
There were two questions here that really had to do with environmental scans, and one has to do with MCO's use of specific tools in conducting care planning and how many states require those. So that's something that, and are there minimum standards or definitions of care coordination and managed care planning? So that's something that I think we can get back to and look at. The other similar sort of environmental scan question is about MCO provider contracts that are fee-for-service based or capitation based, and are they shifting towards VBP? And maybe one of you can address that question, the extent to which contracts from the states and managed care plans are shifting towards VBP, value-based purchasing.
All right, I'll go ahead and start on that. There's not really a great data source on that, but if you do look at some of the contracts as we've seen them across the country, there is more language that speaks to a requirement where managed care organizations must shift some portion of their expenditures toward value-based purchasing arrangements, and in other states where they get actually a bit more prescriptive and actually describe the type of value-based purchasing arrangements that will actually be used within the Medicaid program. So there's definitely growth occurring there. I do still believe that we're early on in that journey, and I do believe it's something that will continue to evolve, but definitely do believe that you'll see further progression in the level of value-based purchasing arrangements compared to fee-for-service in the years ahead.
And I think we have time. Thanks for that, Darren, for the answer for one final question. And that is, are capitated payments adjusted for the risk of the population or based on comorbidities of patients in the MCO? Could you address that question, one of you?
Rates are adjusted for risk of the population. I will say that there are a variety of different risk adjustment tools that are out there, and I do think that, I've yet to hear a consensus on which one folks feel is most accurate in adjusting for the risk of the population. I also believe within Medicaid you get additional challenges in that when you look at risk adjusting, for example, for managed long-term services and supports, there aren't really good tools that account for that population as well. And I do think that's an area that's going to continue to evolve. I know that some folks, particularly I think it was UMass, has been working on actually incorporating gaps in social determinants of health as another risk adjustment tool as part of that process. So I think there's continuing to be some effort to try to advance more sophisticated tools in that space that more accurately reflect the risk of the population that the plans are being asked to serve.
Thank you for that answer, Darren. And I want to begin closing the webinar right now. Thank you, Tom and Darren and Scott, for the really informative presentations you gave today. Thank you to the participants for the great questions you asked. And any answers that we have, we will try to get those back to all of you. I have on the screen right now a reminder of upcoming webinar and our website. We have the third and fourth presentations for this MCO one-on-one series scheduled for December 3rd at 3 p.m. Eastern Time. You can register for that at our website. And that will be discussing MCO authorities under which they operate and strategies for MCO partnerships with various provider and community-based organizations. We really encourage you to go to our Medicaid MCO Learning Hub website, which is listed here. We have a lot of presentations, a lot of briefs, some spotlight interviews with people that are doing really innovative things out in the community, and we encourage you to look there at what's going on with our project. Thank you very much for your participation, and we look forward to seeing you on December 3rd. Good afternoon.